Thank you for joining us. My name is Audrey Hassan, Patient Liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with the answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Azra Raza, a professor of medicine and director of the Myelodysplastic Syndrome Center at Columbia University. Previously, she was the chief of hematology oncology and professor of oncology at the University of Massachusetts. Dr. Raza's research focuses on myelodysplastic syndromes and acute myeloid leukemia, where she equally divides her time caring for patients and supervising her research lab. Dr. Raza has also developed a tissue bank of cancer patients that contains several thousand specimens of patient tissue for her research, which she uses to identify treatment programs for various patients through genetic testing. Dr. Raza has published over 300 peer-reviewed manuscripts in very well-respected blood journals like the New England Journal of Medicine and Blood. She is also the author of over 1,000 abstracts and the recipient of numerous awards, including the Hope Award in Cancer Research. Most recently, she is the author of The First Cell and the Human Cost of Pursuing Cancer to the Last. So with that said, it is my pleasure to introduce Dr. Azra Raza.
Hello, everyone. I'm very grateful to the MDS Foundation for giving me this opportunity to speak today to all of you. While we as oncologists, hematologists, scientists are used to speaking to other colleagues, it is truly an honor to speak to people who are actually experiencing the disease. And the topic that I have been given by the MDS Foundation is understanding disease characteristics of MDS and its progression. You know, when I am feeling unwell, I honestly don't want to speak to anybody, and especially to anyone who doesn't have good news to give me. And the best news usually is when somebody explains to me what is happening, because knowledge is power, and then it allows me also to participate in my own process of getting better. So, with my own experience in mind, I want all of you to relax. I'm not here to give any bad news at all. Rather, I will try and explain to you what we think is going on as the basis for your low blood counts and the disease you have. And don't think I'm going to dumb down and try to use simplistic language, not at all. In fact, there is a deep desire for my patients, who I have been taking care of for over 35 years. I have yet to meet an MDS patient who did not want to know about the disease. And many of you today in the audience have been in my clinic, and you know I use a PowerPoint slide the first time you come to see me to explain what's going on. So let's begin with what are the disease characteristics of MDS. How do we even define this disease? Well, first of all, you need to know that whenever there is something wrong in the blood count, which is how most of patients get diagnosed with MDS, we want to look at the bone marrow. Why? Because that's where blood is made. So the first thing to remember is that it is a bone marrow disease. It involves a stem cell. Stem cell means it is the parent of all the myeloid cells like red blood cells, white blood cells, and platelets in our body. So it is a stem cell apparent cell in the bone marrow. And usually, of course, one or more than one blood counts are low. Now, the defining feature of this disease, though, has to be a lowered blood count, but combined with a marrow that looks abnormal. That's all dysplasia means. So the name myelodysplastic syndromes, shortened into an acronym MDS, which one of my patients said, Dr. Raza, this means my disease stinks, but not exactly. It stands for myelodysplastic syndromes. Myelo simply means myeloid cells, which is red blood cells, white blood cells, and platelets. And dysplastic means those stem cells which are producing those, and the cells themselves look abnormal. That's all myelodysplastic syndrome means. Chromosomes can be damaged in this disease, and we will talk more about it a little later, but this is also a characteristic of the disease. And we have found that within the chromosome, certain genes are repetitively, recurrently mutated, which means that they have retained some abnormality during the process of copying DNA for doubling of the cells. Cytopenias, what does it mean? Simply low blood counts. We don't call hemoglobin as low until it reaches below 10, platelets below 100, and neutrophils, which are a type of white blood cells, below 1800. Now, the diagnostic criteria, that means what clinches the diagnosis is when we look at the bone marrow, and we have to see that at least 10% of the cells are looking abnormal. So here is a normal white, completely mature white blood cell, or granulocyte because it has granules in it. And here are all the types of abnormal looking ones. So if I'm looking at somebody's blood count and I see these types of white blood cells appearing, they have granules, so I know it's a granulocyte, but its nucleus is looking very different, right? And here there are four sort of lobes in this nucleus. Here there are only two. So all this will make me suspicious just by looking in the blood that blood cells are not looking normal. Same for red blood cells and same for platelet forming cells, which are megakaryocytes. So normal early red blood cell, normal early megakaryocyte. And then the second thing is that there is a chromosomal abnormality, or there can be an increase in immature cells called blasts, which I will explain in a minute. It is a disease of older adults. There is a male preponderance, 2 to 1. Twice as many men get the disease, and median age, which means half the patients diagnosed with this disease are older than 70 years. Now, if you look at the incidence of MDS, what you find is that between 35 to 39 years old, it is very rare. But as we age, look at how high the incidence becomes. So that over the age of 70, it is now quite high. And this is why we call it a disease of the elderly. But I have to tell you, I have seen kids as young as 2 years and 2 months even present with MDS. Extremely rare, but we have seen it. What could cause MDS? First of all, we always think that, is there a hereditary predisposition? Did someone else in the family ever have MDS? And this can happen, extremely rare. It is a different kind of MDS known as familial MDS. In my practice of over 35 years taking care of MDS patients, I have come across many such families who have multiple members over generations affected by this disease, but very rare. 99.9% of you who have MDS do not have it, at least right now, as far as we know, because you inherited something, neither are you going to pass it on to your children. Another cause for MDS could be exposure to toxins. Like after the atomic bomb was dropped on Japan, survivors were noted to have higher incidence of this. The same way people who get treated for some other type of cancer with chemotherapy, radiation therapy have a slightly higher incidence of getting MDS. Infections really haven't been associated with MDS as such. So that is a questionable cause right now. Most of the time, we think it is just a random error made by a cell which is doubling its DNA before it divides and becomes two cells. And so it means that you could lead the most pristine life with a great lifestyle and exercise routine, and then suddenly still be diagnosed with MDS. And many of my patients come and tell me, Dr. Raza, I've never even smoked. I exercise every day. Why did I get this disease? Because it is a random copying error. Well, if it's random, why is it happening in older people? Because the stem cells that are the healthiest have been used up to make blood earlier on in our life, so that there is an attrition of robust and healthy stem cells, and one of them has a higher chance of making a random error now. Let's look at how this random error is made. So I wanted to show you in a sort of evolutionary perspective, a Darwinian perspective, what happens. Here is a completely normal bone marrow stem cell. As it is preparing to divide into two, it doubles its DNA, and during the doubling, it makes copying errors. But those errors are usually either corrected quickly, or if they are bad enough, the cell is forced to commit suicide. However, at times, these errors happen to linger and the cell is not killed. So now we produce a cell in our body which has what we call a mistake in the DNA. And this mistake is called a mutation. Now, as a consequence of this mutation, this cell is now an MDS stem cell. The problem is that each time it divides into two, it can pick up new DNA copying errors, and more so. So every time it divides, there are more copying errors, which means more mutations. So by the time we diagnose the disease, here is where we are usually, with lots and lots of mutations. This is why any drug targeting one mutation will work best if we treat the disease early rather than when there are so many more mutations. So I just wanted to show you, like in a cartoonish form, what we are talking about. When I began to study this disease back in 1980s, what I noticed was that here are my patients who present with low blood counts, like anemia, low white cells, low platelets. But if I looked at their bone marrow, it has more than normal number of cells. So if so many cells are being produced, what's happening? I decided to study the proliferation of cells, which is how are they dividing. And to do that, I gave labels called BRDU and IUDR by intravenous infusions to my patients. And these labels would go in and be incorporated in cells which are actively dividing. And so I could measure how fast are they doubling. And what I showed was that this MDS is not a failing bone marrow. In fact, the doubling of cells, the proliferation going on in the bone marrow is twice as much as that of even a normal bone marrow. So where are all the cells going? This is the paradox. If the bone marrow is making more than normal number of cells, what's happening to them? It turns out that they are dying by a very specific process called apoptosis, which means basically that the cell commits suicide before it enters blood. What causes this excessive cell death? Well, first of all, the stem cell, which is now mutated, is defective. It's not completely healthy. But the second issue is that there are proteins in the marrow produced in excess amounts that are also killing off the cells. It means that not just the cell is abnormal, the environment around it has also become unhealthy, toxic, inflammatory, which is killing off even the unhealthy cells. Of course, any healthy cells that are there are also killed. What are these proteins? TNF and TGF beta. And interestingly, blocking these proteins, which are called poisoning the environment, should improve blood counts. I asked myself this question back in 1997, 98, and I was looking for drugs to block TNF and TGF. To block TNF, thalidomide was approved, which is an anti-TNF drug, and I was the first to use it to treat MDS patients and show that 20% patients entered complete remission in terms of their transfusion requirement. And based on my work, this drug Revlimid was then developed from thalidomide for MDS. Many of you may have been treated with it or know about it. This is the reason for its use. A second thing I was looking for was how to block TGF beta, which is also poisoning the environment and killing off the cells. If we stop the killing, we will improve the blood count because the cells will come out in the blood. And now finally, we have an anti-TGF beta drug, which is called luspatercept or Reblozyl, and it is approved for use in patients with refractory anemia and ring sideroblasts. So just to summarize for you, when we find low blood counts in a patient, we become worried that something is wrong in the bone marrow after we rule out other causes of low blood counts like drugs or any kind of nutritional deficiencies, iron deficiency, etc., vitamin B12. Once all those causes are ruled out, then we worry that maybe a stem cell in the bone marrow has been damaged. So we suggest to you that, well, we should do a bone marrow examination. And bone marrow, as you know, is inside bone. So we take a piece of the bone, we put it under the microscope. What we see are the background environmental cells, and then on top are these cells called stem cells of the bone marrow. These are the cells that make blood by first making copies of themselves, and then in addition to dividing, they mature into white cells, red cells, platelets, and they enter blood. Do you know that your bone marrow makes about 1 trillion cells every 24 hours? That is a very busy organ, as you can see, 1 trillion cells a day. This is what happens in a healthy adult. This is how we make blood from the bone marrow. What happens in MDS is we have the background cells, we have the stem cell. One stem cell becomes damaged during the process of proliferation, like we talked about, making a random DNA copying error most of the time. And the result is that this cell now divides faster than the normal stem cell. So by the time normal stem cells divide into 2, the MDS stem cell divides into 100. It's going so fast. So before long, its daughters take over the whole bone marrow. The good news is there is no block of maturation. So still they become fully mature white cells, red cells, platelets. The only difference is they look dysplastic. They look abnormal compared to normal, but they mature all the way. But now the second problem happens, which is that these cells are not as healthy as those. And also because of the presence of poisons like TNF and TGF beta in the environment, these cells, many of them drop dead before entering blood. So now the number of cells entering blood are low, and this accounts for the low blood counts. The next thing that we worry about in our patients with MDS is that what if one of this white blood cells stops to mature? If it remains immature and doesn't become mature like here, these cells are called blasts. Up to 5% blasts are normal, but if it becomes 20%, that's called acute myeloid leukemia. So basically, we have either patients who will continue as MDS and have lower and lower blood counts all the time, or they will develop one of these blasts which keeps increasing in number, and then goes into leukemia. So 2/3 of the patients who present today with new diagnosis of MDS, 70% will have lower risk disease, which means they will only have blood counts that sort of decrease over the number of years, but 1/3 of the patients could present and have higher risk of developing leukemia. There is no single parameter or clinical characteristic which could tell us the difference between low risk and high risk disease. In fact, it's a combination of things. So an international group that wanted to develop guidelines for prognosis of a patient got together back in the 1990s, and then it was revised in 2012. And after analyzing the clinical characteristics, biological characteristics of thousands of patients, what we found was that instead of any one thing, it's a combination of three things that best tell us the prognosis of the patient. How long will their disease continue? And those three things are: what is the percentage of blasts in the bone marrow? What do the cytogenetics or chromosomes look like? And how many blood counts are low and how low are they? And so cytogenetics can be normal, can be single chromosome damage, can be complex damage. You don't have to worry about all these. The only thing is that some types of cytogenetics are good, which means good. By good, I mean that they are patients who have these generally have the long survival without progressing to leukemia, and that they're also amenable to treatment. For example, deletion 5q, when somebody presents just with this deletion 5q abnormality, they generally have a longer survival and can respond beautifully to Revlimid. There are also common genetic mutations, and I've listed some of them here. But the important thing to note is that about 70% of the mutations are in two kinds of genes, one kind called splicing factor, another kind that controls the epigenetic phenomena, not just the genes, but genes are not controlling, but something above the genes is controlling a lot of the activity of the cell. And some of those kinds of controlling mechanisms are very important in MDS. So here is how we now look for prognosis by the IPSS, International Prognostic Scoring System, that was revised in 2012. As I said, we look at cytogenetics and we assign a score. If they're very good cytogenetics, then we say the score for that is 0. If they're very bad, then the score keeps increasing. The same way for percentage of blasts, less than 2%, 2 to 5%, 5 to 10, 10 to 20, and hemoglobin, how low is it, and platelets, and ANC. So you can put all these parameters and come up with a score, and that score tells us whether the patient is going to be low risk or high risk. So if your score is lower than 1.5, that's a very low risk disease, and most of the patients will survive beyond 10 years. But if it's very high, then the score is over 6 and survival will be affected by that. The problem is that it's not completely accurate. You may get a low score, but a lot of people with just a low score have been found. If we just look at lower risk disease, we find three types of patients. One who survive, half of them beyond 9 years, another who survived beyond 6 years, but a third who just survived 2.5 years. And they have all been classified as lower risk disease by IPSSR. So the reason I'm telling you all this is that don't become too tied up with scoring and accuracy of prognosis, because honestly, after 35 years, one of the lessons I've learned is that the best way to find the prognosis for an individual patient, I can say, oh, 50% chances you will do well, or 80% chances that you will do well. Well, where are you in that 20% or 80%? How do I find that? How do I apply a statistic developed on a population of patients to an individual sitting across the table from me in the examination room? This is why I say to you, the best way to really understand the prognosis of your individual disease is to follow your disease in clinic in your body. And so I never rush to treat MDS patients, because even though they look like low risk, within 3 months they may show signs of high risk. On the other hand, some people who we think are presenting with some adverse features that seem to indicate they have a high risk disease, you know what? I have seen those patients continuing for 10 years without any serious ramifications of the disease. So while most of the time these numbers apply, these are not hard and fast, etched on stone kinds of things. The best thing is for you to talk to your hematologist about what is my score, what is my chance, but then always remember that the reason why we treat you as an individual is because you can have very unique pattern of the disease. So this was all about characteristics of MDS. You know, we talked about how the disease happens in one single stem cell, but that stem cell divides rapidly, takes over the bone marrow. It still is able to become mature red cell, white cells, platelets, though they look dysplastic, but all of them don't make it to the blood, so the counts start falling. Then one of them can stop maturing, and that means blasts increase and towards leukemia. 2/3 of the patients have lower risk MDS and will live a long time. 1/3 have higher risk disease, and even some of them will live a long time. Remember, only 1/3 of the patients, even with very high risk MDS, will develop acute leukemia. So the incidence of leukemia is 30%, even in those who have very high risk disease. Now we'll talk about what happens as the disease progresses. And to show you that, what I want to do is just present a case. Here's a 61-year-old man discovered to have borderline anemia. Hemoglobin's 11, white count is 4.6, platelets are 255, which means that actually none of these qualify as MDS. So what does the patient have? We do a bone marrow and it has less than 10% cells which are dysplastic. So we can't call this man as having MDS. What we call them is ICUS, idiopathic cytopenia of undetermined significance. It means there is some cytopenia, which means lower blood count, but it's not low enough to be called MDS, and the bone marrow doesn't show MDS. So it's idiopathic, unknown cause, cytopenia, low blood count, and we don't know where it's going to go. It means there is a meaningful cytopenia, but it does not meet the minimal diagnostic criteria for MDS, which is 10% cells must show abnormalities and maybe increased blasts, maybe abnormal cytogenetics. So what happens to this patient? He's followed for a year with periodic counts, and then from the blood we have been sequencing and we find a mutation suddenly in the gene SF3B1. Well, does the patient have MDS now? Because remember, SF3B1 is a gene that is commonly mutated in RAAS type of MDS. So what is the patient's diagnosis? No, it's not MDS yet, because for MDS, remember, you have to have dysplasia. So now the diagnosis is not ICUS, but CCUS, which is clonal cytopenia of undetermined significance. It means we are seeing a clone of cells with a mutation, but still there's no dysplasia. So what does ICUS really mean? It seems that they behave more like a lower risk MDS, especially when there is a mutation. So 1/3 of ICUS patients can show a mutation in a gene, so that means they are CCUS, and then those somatic mutation that changes to CCUS behaves more like lower risk MDS. But the 2/3 of ICUS patients will continue just with ICUS. So you may hear these terms bandied about, ICUS, CCUS, and then there's another term called CHIP, which stands for clonal hematopoiesis of indeterminate potential. What is this? This is something very strange. Here the blood counts are completely normal. Well, if the blood counts are normal, But we discover no bone marrow disease, yet we find a mutation in the patient's blood, one of the cells. So why did we even look for a mutation if the blood counts were normal? It turns out that we were sequencing a lot of normal and healthy controls and started finding that in older, completely healthy people with normal blood count, we could see some cells with carrying the mutations which are typical of MDS, but yet the people don't have MDS when we did the bone marrow. So we call them clonal hematopoiesis of indeterminate potential, or CHIP. Less than 1% of these people will develop MDS. In fact, it's associated more with other diseases like strokes and heart attacks. These 99 patients with known heart disease and 79 patients who were centenarians, imagine over 105 years of age, were compared, and it was found that the prevalence of CHIP and heart disease was almost 20% in patients who had CHIP, but the prevalence of CHIP in centenarians was almost non-existent, which means that if you get if you're healthy, no blood counts are low, yet you go to 23andMe or some other DNA sequencing company and get your DNA sequenced and suddenly find there's a mutation, and now you're going to start worrying about, oh, I have CHIP, am I going to die of MDS? No, you're going to die of no, none of those things. So however, there is something associated with it because centenarians do not have CHIP. So turns out that up to 20% individuals in their 60s and 50% in their 80s will have CHIP. What happened to our patient? We followed the patient for another year, and now he suddenly develops worsening anemia, bone marrow is repeated, and now we see dysplastic changes, along with appearance of 20% ring sideroblasts. So we cytogenetics normal, mutation in SF3B1 as we had already noted. So now the patient is diagnosed with MDS and RARS. What is RARS? This means refractory anemia with ring sideroblasts. 35% with low risk MDS patients will present with these ring sideroblasts. What are they? That means an early red blood cell in the bone marrow is surrounded by a ring of iron. I call it poverty in the midst of plenty. Why? Because there is plenty of iron, but the cell is unable to use this iron or heme to combine it with the protein globin to make hemoglobin. So iron keeps getting trapped around this circle in mitochondria surrounding the nucleus. And this very typical formation is associated with a clinical syndrome that is associated with, a lower risk disease, a mutation in the gene SF3B1, and a very excellent response to this newly approved drug called luspatercept. So it is a specific, definitive clinical entity. If any of you MDS patients listening to me have RARS, this is the disease you have. Further disease progression in patients, our patient appeared like this. Another 6 months, the anemia kept worsening and is now fallen to 7.6. So over a period of few years, we got the diagnosis of RARS and the hemoglobin has fallen from 11 grams to 7.6, which is pretty low. And now we need to do something. The white count platelets still normal. What do we have to do now? We have to worry about the anemia. We repeat a bone marrow, we find an additional mutation in the gene P53, which is not a good one, but the patient has a good mutation also. So these things are the confusing parts, that SF3B1 is a mutation that's associated with a very good prognosis. P53, not so good prognosis. So what happens when the two coexist? We are trying to understand it. So the patient gets treated with erythropoietin, Aranesp or Procrit, but doesn't respond. Next, because the patient had ring sideroblasts, got treated with luspatercept, had a great response. But then after a few years, again, the counts start to fall. And this has happened to many of my patients because I participated in the phase 3 clinical trial. So I was treating patients with luspatercept 4 or 5 years ago. And now some of them, after responding for a while, stopped responding. Why does that happen? Why is someone who's responding nicely to a drug stops responding? I thought I'll show you like a cartoon of it. Remember what I said, that MDS starts in one single stem cell, which becomes the normal stem cell, becomes an MDS stem cell because of a mutation. So then it starts dividing rapidly and fills up the whole bone marrow. Again, I also showed you earlier in that tree pattern of Darwin that each time one of these cells divides, it picks up new mutations. And so subclones are formed which still have the founder mutation in them, but now pick up new mutations. So let's say now we come in with treatment, whether it's Reblozyl or luspatercept or Vidasa, Dacogen, Inqovi, any of the approved drugs. We come in with treatment, and the dominant clone of cells is sensitive to the treatment. Those cells will die, and the patient will enter remission, and the counts will improve dramatically, and no more transfusions are needed. Everyone is celebrating, and this response can last even many years. But then very slowly, one of these subclones that were just sitting around but not sensitive to the drug we were giving start to expand. And slowly they start expanding their population till it fills the whole bone marrow. And that's what causes relapse, which means a sequential activation of clones that were sitting around biding their time. And now this clone expanded in the presence of treatment we were giving, and so it is resistant to that treatment, right? By definition, because it expanded in the presence of treatment. So now counts will fall again, and we'll have to come up with another drug. I wanted you to understand this clearly. Why do people stop responding to one drug? Because a resistant clone of cells has expanded. So we need to come in with another drug to treat. Well, our patient failed RNS, responded to luspatercept, then we tried hypomethylating agents, which are either Vidasa or Dacogen or Inqovi, after 6 cycles, but he didn't respond. And patient has now received many transfusions since diagnosis, and there is iron overload. So, many of you who are getting transfusions regularly must be concerned that each time we give a blood transfusion, we are giving a lot of iron with it, which starts getting deposited in liver, heart, etc. So, how do we measure if there's iron overload? One simple measure from the blood is serum ferritin. It's inexpensive. The problem is that serum ferritin can be high, not just because of iron overload, but sometimes because of infection. It can go sky high, or some kind of inflammation. And so we have to be careful about it. We clearly know that serum ferritin level correlates with overall survival. So if the ferritin level is less than 1,000, survival is great. If it is higher than 2,500, it can affect survival. So we try to bring the ferritin level down by giving chelation therapy to patients who are getting repeated transfusions. Now, another way to to investigate whether there's iron overload or not is to look by this special kind of MRI called T2 Star MRI. I just wanted to show you. Here's like a normal MRI showing you lungs and liver and kidneys and spleen. Okay. Now this patient gets a lot of blood transfusions, so there is iron overload. You see how black the lungs are, the liver and spleen and kidneys are white. After many blood transfusions, look at this scan. Look at the liver. It looks black like the lungs. And look at the normal liver. That's what it should look like. Now it is 90% saturated with iron. And yet, you know what? The liver function tests were completely normal. This is the miracle of our bodies, that we can replace the 90% of the liver with iron, and yet the remaining 10% will keep functioning to meet the body's needs. So we have to be proactive, not wait for liver functions to go down, because that would mean that less than 10% is left functional. We need to keep account of how many transfusions patients are getting and know that disease progression could be much worse in terms of cytopenias if there is too much iron. And that's why after 20 transfusions, and if the ferritin is over 1,000, we should really consider starting our patients on chelation therapy if they're getting repeated transfusions. What happened to our patient now? Well, patient failed RNS, luspatercept, Vidasa, remains transfusion dependent, but now experiences worsening of. Remember, the white count platelets were normal until now. Now they are even there. These two are falling along with the hemoglobin. So we repeat a bone marrow, which now shows increased immature cells or blasts. There are new cytogenetic abnormalities. There are new mutations. So what do we do for this patient? Now the patient has gone from lower risk disease to higher risk disease, which means with the increasing blasts, we are worried that now patient could develop leukemia. Patient is still under 70 years of age, so we offer a transplant, which he accepted. Successfully transplanted. This is a case report of one of my patients I have presented to you from an unrelated donor, actually. And after a stormy course, he was discharged, recovered now to pre-transplant health, and has just returned from a vacation in Bermuda. How wonderful is that? So now he's finally cured of the disease after living with it for practically 9 years. So in summary, I've shown you that there are conditions that even before MDS, pre-MDS conditions called ICUS, CICUS, and CHIP. Anemia is the major problem for the majority of lower risk MDS patients. Genetic profiling is helpful. We have luspatercept for lower risk disease, higher risk disease, and COVID. These are the two new drugs. And of course, lots of experimental trials. I'm about to end my talk now. Thank you so much for your patience. I wanted to end by showing you where the future is going. So listen, I started my career in oncology by studying and treating patients with acute myeloid leukemia. But before long, I realized that this disease is very complicated, and the best way maybe to treat it is try to catch it early. You know, when patients are diagnosed with any kind of cancer, the only good news that comes that you can give them is, don't worry, it's diagnosed early and we can treat you. That's what I thought about AML also. How can we diagnose it early? Well, many of my patients were giving stories that, Dr. Raza, before I was diagnosed, I've had low blood counts for a year or 2 years or 5 months. And that started me thinking, well, that's the pre-leukemia stage I should be studying. So I turned my attention to studying pre-leukemia, which is MDS. And my idea was that we should study MDS patients and intercept before it becomes acute leukemia. And at that time, one of the things that I did was, back in 1984, I said, well, I'm going to study my patients to help them. That means I should save their sample. So I started banking, just putting blood and bone marrow samples on my patients in my freezers. And today I have collected the largest tissue repository in the world on MDS patients who have been followed since 1984. We have more than 60,000 samples and all their pathology and clinical information. If there are patients in the audience who've been through my clinic, you know I asked each one of you to donate your sample when I'm doing a bone marrow on you, to donate some extra marrow and extra blood for the tissue repository. I don't remember the last patient who refused me. It is so humbling and a moment for me when I ask for your permission. And universally, the answer I get is, Dr. Raza, even if it doesn't help me, it might help someone else. And that always makes me want to cry, because that is such a noble sentiment. I really thank you for it. And I promise you, not one single cell here has been contributed by another physician. I do the bone marrows to this day myself. I draw the blood on most patients myself. And we are working with investigators all over the world to use these samples to advance the understanding of this very complicated disease. I do feel that earlier detection is better. So what I started by studying acute leukemia, I went to pre-leukemia, but I realized even by the time we diagnose leukemia, we diagnose MDS, the whole bone marrow has been replaced by those clonal cells. We need to diagnose even earlier. And also, one of the most serious threats to life of an MDS patient is developing leukemia. By the time we diagnose it, 20% of the cells at least are already leukemia cells in the marrow. I said to myself, how do I pick the first leukemia cell before it's become 20%? That means early detection. My idea is we should be monitoring wellness to find the footprint of illness and first appearance of the disease. So we can take periodic blood samples on MDS patients and see if we can detect the first leukemia cell. So we started, you can detect these first tumor cells from many solid tumors, but I'm saying that even in a liquid tumor like MDS and acute myeloid leukemia, we can pick this early. We are using this machine that is called the ISET technology, isolation by size of epithelial tumors. And the idea here is very simple. I want to explain it to you. This machine literally has something like a coffee filter that allows this small sized blood cells to go through it, but a blast which is larger will get caught on the filter. And we can pass 10 ml of blood from an MDS patient through the filter, and we can pick up one leukemia cell out of 50 billion blood cells. One cell out of 50 billion. We are starting to see some of these early cells. Here is an example. This is what the first cell looks like. From the blood, I have caught this in a patient who has just MDS. No evidence that this patient has leukemia yet, but we are picking up these cells. I showed it to our hematopathologist and he said, yes, Azra, this is a giant cell, polyaneuploidal, this is in the blood. So it is a harbinger that this patient might get leukemia soon. But now is the time to act. So what do we do when we find the first cell? Now what? How do we zap that cell out of existence before the MDS patient gets leukemia? For that, we need to study the individual cell. And so we are working on single cell analysis using genomics, epigenomics, proteomics, transcriptomics, metabolomics, all these things. And once we find the right target, that's when we can identify the lineage, the heterogeneity, and specifically design targeted therapy to hit that one cell and zap it out of existence. And that is how we will be able to finally have the dream of prevention rather than treating with horrible therapies, advanced acute leukemia. We should be able to prevent acute leukemia from happening. I'm very excited to report to you that all this is going on right now. Thank you for your time. Thank you for listening to me. I dedicate this talk, first of all, to thousands of MDS patients I have taken care of over the years. And thank you for showing me how your endurance and your courage is the helium for our spirit. We work together. We are on this journey together, taking you through some hard times, but then good times when you respond. And I'm particularly grateful to all those who are willing to donate their blood and bone marrow to the tissue repository. And as a result, if I had a choice between a walk on the moon and saving one life from cancer, I would never look at the moon again. Thank you so much. Have a nice day. Happy to answer any questions now.
Hello, my name is Janice Butchko, and I will be moderating today's live Q&A. I would like to thank Dr. Raza for her wonderful presentation. We will now start the Q&A. Please submit any of your questions through the chat function. Dr. Raza, are you ready? Okay, we'll start with our first question. We have a question from Ambuja. What are the signs of 5q minus progressing into AML?
This is a very special type of myelodysplastic syndrome, so with a very good prognosis. This can go on for many years without requiring any treatment actually, and when treatment is required, there is a very good drug Revlimid which can produce responses in over 70% of patients, and the response can last many years. But eventually, when the individual who has this kind of disease can start showing progression in terms of falling blood counts, and usually it is anemia that gets worse. When that happens, we usually perform a bone marrow to look at the origin of where everything is happening, and the bone marrow can show also some increase in blast or some additional chromosome abnormality. Those are all signs of progression. The most common, as I said, would be a change in the blood count, and amongst the blood count, the most common one affected is hemoglobin. I hope that answers your question.
Wonderful. Thank you so much. I'm going to go on to another question from the same person, Ambuja. So does low blood count cause head banging in the night? I'm not quite sure what head banging is. Perhaps you've heard of that?
Yes, actually, a number of my patients will complain of it, and it is not unusual to feel a kind of throbbing, banging sensation in the in the head even, and that is a sign of anemia, yes.
Great. Thank you so much. I'm going to go on to our next question. This is from Kim. Does MDS have any association with toxic exposure to 9/11, to the 9/11 tragedy?
It is really not completely certain, but very unlikely. So far, we have not seen an increased incidence in individuals who were exposed to the dust storms and the kind of toxic fumes that came out after 9/11. The only chemical that MDS has definitely been associated with development of MDS after exposure to the chemical is benzene. And that is the reason that over 50 years ago, benzene was completely banned in the United States. At the moment, I can't say that there is any relationship between toxic exposure to 9/11 miasma and MDS.
Okay, thank you very much. So next question, is there a way to keep blast counts low, like periodically during Dacogen? So that's from Fred.
Okay, that is what we try to do with some of these therapies like Dacogen, that we can keep the blast count down, and in a number of patients it is very effective and it can keep it down for a long time. Yes, so the answer to your question is, can we keep the blast count down? Yes. How many patients? It's not certain. We have to try it, and at least a third of the patients will definitely have a great response, and another third will have a partial response. So yes.
Thank you. The next is actually from someone whose wife is a patient of yours. They live in Vermont, and 11 years RAAS transfusion dependent, for 11 years transfusion dependent, 8 years. Yesterday she had, and you'll have to forgive me, I'm reading from here, 2 PRBC and Neupogen. And can she receive the COVID-19 vaccine? That's the question.
Yes, the answer is a resounding yes.
Wonderful. Okay, see, going down on my list now for the next question. With low-risk MDS diagnosis with multiple chromosomal abnormalities, do you find treatment options are less effective?
It's interesting that in the past we used to get a lot more concern when we saw multiple chromosomes damaged. But over the years, one of the things we found is that individuals who have a lot of chromosomes damage can do quite well for many years as long as they don't have a mutation in the gene called P53. The combination of having a mutation in P53 and having multiply damaged chromosomes is not a good combination. But by itself, just damaged chromosomes, people can live for a long time.
Wonderful, thank you. So next question, I have had MDS RS for 12 years. Luspatercept has helped, but not made me transfusion independent. I've been able to deal with shortness of breath until a year ago when fatigue drastically increased. Is this because there is a drastic increase in cancerous stem cells or something else about the disease?
It's not unusual that with time, number of abnormal cells in the bone marrow will keep expanding. And with treatment and response to treatment, like your partial response to luspatercept, some of that could decrease. But increasing fatigue normally comes either from low hemoglobin or side effect of the drug. So if you're still on luspatercept, then one of the known side effects that many people suffer from is increasing fatigue. It is very important for you to address this question with your hematologist. For example, what dose of luspatercept are you on? Can that be reduced? Or should we try to keep your hemoglobin a little higher than it was in the last several years because you are requiring, because you're symptomatic with the anemia now. So it is a sign that either it is disease related or drug related.
Wonderful, thank you. Next question, this is from Brian. 72 weeks with a hemoglobin average of 5.5, receiving 2 units of blood every week. What's the best treatment to get off of transfusions, at least to reduce them? He also adds, I'm about to start methotrexate. They think I have LGL leukemia.
That is the best treatment for LGL. So whoever is treating you is doing the right thing. That's what I would do.
Wonderful, thank you. Next question, if one has been under treatment of azacitidine is managed to be in remission, blood counts all normal for 10 months, is it okay to stop or lessen the treatment?
Usually we continue the same exact treatment for at least a year. And once the counts are normal and you receive treatments for a year, then we can do one of two things. Use the number of days for which you are getting the azacitidine. For example, if you started with 7 days, you can go to 5. If you started with 5 days, you can go to 3 days every 4 weeks. Or you can increase the duration between the cycles of azacitidine. So if you were getting, let's say, 5 days every month, we could do it 5 days every 6 weeks. But I would wait till for the whole year of treatment with azacitidine and then make one of these changes. And with time, we can make both changes, that is, give lesser days of the treatment and increase the interval between treatments as well. But it all can be done slowly, and as soon if there is any change in the blood counts, you have to go back to the old routine, which was working.
Perfect, thank you. Next question from Karen. I have MDS 5Q- for 2 years. Is it better to start treatment with Revlimid early or wait until blood counts get worse?
Yeah, that's a good question, because in the past, the way Revlimid is currently approved is lower risk MDS with deletion 5q who are transfusion dependent. So by definition, according to the FDA, you should not be getting Revlimid early. However, just this December of 2020 at the American Society of Hematology meeting, a study was presented where they gave the Revlimid earlier on before individuals became transfusion dependent, the question you are asking. And the answer is yes, it works better and for a longer survivor if you start early. However, I'm not sure if in the US they will let us do it yet, because it's not FDA approved.
Thank you, very helpful. Next question, how are genetic defects detected?
By special sequencing of the DNA. So we take blood or bone marrow work, and we separate out the cells from the rest of the plasma and serum, etc. And then we sequence the DNA of these cells and find the recurring mutations that we talked about. Normally, we don't sequence the whole DNA because we know that there are 40 mutations, that 90% of mutations would be within these 40 genes. So we just do this targeted 40 gene sequencing and usually find in about 70 to 80% patients we'll find a mutation.
Wonderful, thank you. This one's from Kathy. It's long, bear with me. Kathy says, thank you for your explanations. I was diagnosed with MDS close to 3 years ago. I was told it was low, but no real diagnosis. After a year and a half of watching my hemoglobin going down, oncologists put me on RAAS. I've now been on it for almost a year and it's working well. Is there any reason to have another bone marrow biopsy? I was told I have no blasts, but my red cells are too large and die off too fast. I am trying to figure out, do I need to explore my MDS more?
That's, yeah, that what you are saying and what you're pointing out is a real dilemma in the field. We diagnose a disease in our patients that, look, your blood count is low and you have MDS, but we got to wait till the blood counts keep falling lower and lower. Well, many people ask me, Dr. Raza, why aren't we doing something now when it is the early stage of the disease? And the reason is that the treatments we have really are not that effective against the early stage of the disease. All we can do is improve the blood counts rather than get rid of the disease bone marrow. And that is why we wait till your one of the blood counts is low enough to require treatment, and your doctor, your hematologist is doing the right thing, that when the hemoglobin fell below a certain level, they initiated treatment with this hormone erythropoietin, and they see a response. Personally, I do bone marrows once a year for my patients, even with lower risk disease, because like I showed you, a third of the lower risk patients can really show changes in the bone marrow which are not apparent in the blood count. And so you may look like you're responding in terms of your hemoglobin improvement to RNS, but the disease in the bone marrow could get worse. I don't want to scare you, so don't think I'm giving you a doom and gloom situation. I'm telling you, not knowing anything in detail about you, that my practice is that to be on the safe side, once a year, even in lower risk MDS patients, I repeat everything, restage the patients, make sure their disease is where it is, because God forbid when it shows progression, then I'm able to look back and say, oh, not 4 years ago, 3 years ago, I saw a little something, but last year, or that it has been normal until now. So it's very helpful to have that kind of information. I do think you should at least have it once a year, and definitely if there is any change in the blood count.
Perfect, thank you. Next question is from Madeline. My mother has MDS 5Q- for around 5 years. She's 85 years old. She's tried Reblozyl, but her hemoglobin remains in the 7s. What other drugs might she try?
Sorry, what was the diagnosis? I missed it.
MDS 5Q-. Yeah, 5Q-.
Right. So the treatment for her should be Revlimid. I'm surprised that she got Reblozyl rather than Revlimid. Treatment would be Revlimid. And if she has ring stars, then Reblozyl.
Right. Thank you. Next question. It doesn't have a name here. It says, what does death from MDS look like? Is it infection? Is it pneumonia? How can you answer that?
Whether patients with MDS develop acute myeloid leukemia or not, the final event is always because of low blood counts. And what low blood counts can do is make us more susceptible to infection and bleeding. And those are the two most common causes.
Sure. Thank you so much. I see there's a question here from Anna Krupa, and I'm just going to let you know that there are many questions within here, and we'll send that off to Dr. Raza and see if maybe she can help us out through email after the event. Next question from Michael. Will most insurances pay for second opinions, and most recommended treatments for MDS will Medicare?
Yes.
Wonderful. This is from Robert. I was a patient of yours about 10 years ago. You tried through clinical trial Revlimid and Vidasa, but they did not work for me. I see another doctor from Yale and have been getting 2 units of blood every 2 weeks for at least 10 years now. My ferritin level's been between 800 and 950 for a long time, and my MRI or liver have been good. Do you have any advice for me regarding future clinical trial, or should I just stay the course? So good to see you again.
Same here. And I'm so happy that you came on and said all this, because this should reassure a lot of patients who are online right now that it is perfectly safe and possible to get blood transfusions for 10 years. I know there is one of my patients on today who has joined us from Chicago, who has been on 2 units of blood every 2 to 3 weeks for over 15 years now, and leads a perfectly normal, great quality life. So thank you, Mr. Robert, for saying that you said. All I can say is that the Yale team is treating you very well, and they are keeping your level down and not allowing the iron to accumulate, and that's the safest way of giving blood transfusions. We would love to get you off transfusions, but there aren't that many drugs available or that many trials available for the lower risk RAAS type of MDS that you have right now. If you have Reblozyl and not responded if you had RAAS, then we have another trial with a drug called imetelstat that's looking good, but it is only available for people who have not received prior treatment. So you wouldn't be eligible for it, but in the next year or two, we hope it will be approved, and then that would be an option for you to get off the transfusions. I think constantly we are exploring and investigating and researching new agents that are coming on and will be helpful for you. Not right now, though.
Wonderful, thank you. Next question is from Ron. Is there a difference in progression of MDS between MDS caused by benzene contamination as compared to MDS caused by a genetic mutation?
Depends on the genetic mutation and depends on how what kind of MDS have developed after the exposure to benzene. But I think I can safely say that the whole, the kind that develops after exposure to a toxic agent like benzene is called secondary MDS, and that does seem to
progress faster. Okay, thank you. Next question is from Lori. My husband has had 2 transfusions, red blood and platelets, twice a week since last August. How long can he keep doing that? His ferritin level is still at 2,700 and started XJ 1 month ago, so hopefully it will start to go down.
Yes, I definitely go down. My advice is that you see, you're getting XJ and trying to get rid of the iron, but you're also continuing to get blood transfusions. So you keep adding a lot more iron all the time as well. And this is why there are many fluctuations. But on the whole, the curve of ferritin should start coming down. And then suddenly you might see a nice decline. So the idea is,
I think they're asking you to take your phone off of speaker and maybe hold it to your ear so that it's a little bit clearer. Now we're getting a bit of interference.
Yes, it's not me though, darling. There is someone else whose mic is on.
I understand. Yeah,
So I know you keep blaming me, Tracy. Sorry. Just kidding.
I'm sorry. We're doing our best. Thank you so much. That was great. So we have our next question is from David. Thank you, Dr. Raza. Do you have an opinion regarding converting from IV decitabine to oral Inqovi? I've completed 25 cycles of decitabine with favorable results and would welcome the conversion to Inqovi for convenience, but worry about achieving the same result. That's a good question.
Yes, I'm actually have changed a number of my patients from taking Dacogen to Inqovi because it's a no-brainer, especially in this day and age of COVID-19. And our hospital, you know, sees a lot of COVID-19 patients. So the more I can avoid trips to the hospital for my patients, the happier I am. And if they can take the treatment at home by this oral Inqovi, then I think it's a very good option. There are no head-to-head trials to show that you can switch after 25 cycles of Dacogen to Inqovi and there won't be any issues. But I can assure you that it is the same drug. It is Dacogen, but with the addition of Azuridine, which is an agent that blocks the elimination of Dacogen by the liver. So what happens is Dacogen is available for a bit longer. And that's why it's important to dose it correctly, because otherwise your counts could go unexpectedly down because it's more effective since it is combined with another agent. I think I would safely be able to switch you to Inqovi, yes.
Wonderful. Thank you. Next question is from Doran. What are the possibilities for imetelstat and makrolumab as a new agent?
Good possibilities coming up.
And we hope that magrolimab, which is the anti-CD47 antibody, is looking very exciting, very interesting in a number of specific subsets of MDS patients, like those who have P53 mutation, which we used to be very worried about that it has adverse prognosis, can respond very nicely to this antibody, magrolimab. And imetelstat, we are very excited about. Phase 3 early results have been presented in the first part of the phase 3 results, which show a good 40% patients responding. So we are with lower risk disease. So we are very excited about both imetelstat and magrolimab, and good things are coming on for MDS.
Wonderful, very hopeful. The next question is from Ron, and I think we touched on this before, but how often should a patient get a bone marrow biopsy?
For higher risk disease, it can be more often, but for lower risk disease, at least once a year. And anytime there is a change in blood count or change in the condition, symptoms of the patient, anything to alert us that there is disease progression possible, a bone marrow should be done. I'll give you an example. I had a patient and I did a bone marrow on this patient in January. And this was a yearly bone marrow. It's not like the patient's counts had changed very much, but I like to do a yearly bone marrow. So as I said earlier, so I did a bone marrow in January, which was his annual marrow. His hemoglobin was 11 grams at the time. And then in March, the bone marrow looked perfectly fine, low risk MDS, the way it had been for 4 previous years. Can you believe that in March, my patient's hemoglobin suddenly fell to 9.5? And patients generally assume, the best explanation. He kept telling me, Dr. Raza, this happened because I had flu, and it could be because I was helping my mother in Florida. I was doing all the plumbing for her apartment and things like that, he was telling me. But as doctors, our job is to assume the worst and then work our way down. So I said, listen, you may be right that this fall in hemoglobin, he kept saying, you just did a bone marrow on me in January. I said, no, if I see a change in your blood count in March, even though the marrow was fine in January, please let me repeat the marrow. And it took a little bit of convincing, and he finally agreed. And this time the marrow had, don't get scared, this is a very unusual case, but his marrow had 80% blast, which was such a shock to all of us, because at most I was expecting that, okay, there may be a little bit of disease progression. But the idea I'm saying is that there are occasionally we see cases where there is a sudden change. And now from January, if I hadn't done a bone marrow in January of that year, I would have thought that, oh, this disease, this blast count has been increasing probably since the last year or two since I last did the marrow. These are the kinds of cases which convince me that, one, we should do an annual bone marrow so that we can use it as baseline when any change occurs later. And so the answer to your question, sorry for the long-winded answer, but the answer is a lot of time it depends on when the disease shows signs of any kind of change, but at least once a year.
Wonderful. Thank you so much. Next question from Lisa. What is the best way to monitor the progress of my disease? I was diagnosed with low-risk MDS at 49 with dysplasia in red, white, and platelets. After responding to Procreate for the last 15 years, my red blood cells are no longer showing these platelets. However, I've been told that epigenetics are affecting my energy levels, even though the cells look relatively normal now.
I think the best way to monitor is to do the periodic regular blood counts, and in addition, follow it up with a bone marrow once a year at least, or if you are showing sudden new constitutional symptoms like increased fatigue, we should repeat that. We should do genetic profile again. You have to mute everybody else, Tracy, because there's so much disturbance.
I know, I'm hearing that as well. I think when they mute, though, I have to quickly unmute myself. So we'll mute everyone, and then I'll unmute myself because I'm hearing the background as well.
So as I said, I think it's very important for you to be followed carefully with blood counts, and then bone marrow or genetic profile from the blood to look for new mutations that might appear periodically, for sure.
Wonderful. So I have a question from Marie. Is there any, and we have about 5 minutes left. We're going to quickly go through as many more questions as we can from Marie. Is there any research into targeting the mutated stem cells when caught very early to limit the number of mutated stem cells for a longer period of time? My husband has Del 20Q type, but on shows in 9 out of 20 samples. I think maybe only shows. Is there a way to eliminate just the deformed cells and leave the healthy ones to replicate for more normal cells? Is that clear?
Thank you, Marie. Yes, very smart woman, Marie, and thank you for sharing this story about your husband. First, let me give you the good news. The kind of chromosome abnormality he's showing in 9 out of 20 metaphases is deletion 20q. That means the long arm of chromosome 20 is missing. That is a particularly good prognosis kind of abnormality. It is better than having normal chromosomes. If you have deletion 20q, that is associated with a longer survival than any other type of MDS. And that is exactly the next question you're asking is, well, right now, 20 metaphases were analyzed and 9 of them had this abnormality, 11 did not. How can we prevent the disease from now going from 9 to 18 to all 20? This is what we are trying to do. Target the first cells and target the abnormal cells only and zap them out of existence. Those are the technologies that are under development now, and very soon we hope to have targeted therapies only for the abnormal cells. At the moment, we can target a few mutations, for example, any mutation in the genes IDH1 or IDH2. There are inhibitors for IDH1, IDH2 available. Patients who present with p53 mutation, they can also respond to a drug APR246, which is under study right now. But like I said earlier, magrolimab appears to be effective in people with the p53 mutation as well, and specifically targets the mutated cells, we think. But still, it's a long way from providing cures to these individuals. As I said, fortunately, your husband has lower risk MDS, and the deletion in chromosome 20 is associated with a long survival. So I think you can relax a bit and let us develop these targeted therapies in the next few years. Keep reading and keep the knowledge base expanding the way you seem to be doing. Thank you.
Wonderful. Thank you so much. All right, this will be our last question. Again, we're gonna hope that Dr. Raza is able to answer the remaining questions through email, which we'll then post onto our website along with this webinar. But I wanted to end it on a COVID question. We're going to be doing a specific COVID vaccine webinar coming up soon, but this is a question from Michael. As an MDS patient with neutropenia, I'm curious as to the effectiveness of COVID mRNA vaccines. Also, would the J&J vaccine be a vaccine that would be acceptable for an MDS patient with neutropenia?
Yes, the answer to your question is that even though our MDS patients have neutropenia or low white blood count, the good news is that they don't get repetitive infections. You just heard someone having MDS for 10 years. He didn't say that every 2 weeks I needed to be admitted in the hospital with pneumonia. The reason is that the blood counts the white cells are low in the blood, but they are present in the tissues where they're needed in normal numbers. And so the immune compromisation is not the same that the kind you see after giving chemotherapy and destroying a lot of white cells, for example. So I think to answer your question, it's perfectly safe to take the vaccines, and they will produce the immunity that we are trying to instill in the patients, in the subjects with the vaccination. There is no difference really between using the J&J vaccine or Moderna or Pfizer or the Russian kind of vaccine, because they are all using basically the same principle, which is to stamp the memory of this protein into the into the immune cells in our body so that they remember. And as soon as they are exposed to COVID-19, these cells that have the memory will come out and kill it. And so any kind of vaccines will work, and it's perfectly safe to be neutropenic and to get the vaccine.
Wonderful. Thank you so much. So that's the end of our program today. Dr. Raza, I cannot thank you enough for your presentation and also for thoroughly answering all of these questions. We'll be sending the additional questions through. Thank you all for attending, and have a lovely rest of your day.
Thank you, everyone. Really honored to be here. Bye, and have a good weekend.
Thank you. Bye-bye.